It's time to focus up, okay? The time for silliness and goofing around is over, okay? Over. Myasthenia gravis. So last time we talked about MS and GBS, multiple sclerosis and Guillain-Barré syndrome, whatever, okay? Big thing with MS, it's due to a degradation of the myelin sheath at the central nervous system level, okay? The first initial signs of a good solid MS are going to be some weird sensory things, anything you can touch, taste, see, feel, weird kind of pins and needles, maybe some double vision. It's kind of just strange sensations. Maybe you're not able to smell or something. And there are things that can cause exacerbations of MS, okay, where it gets a lot worse, where maybe that smoothness of movement or the sensory kind of deal is way off, right? This can put them at risk for tremors, sort of that's, bad tremors, massive weakness, fatigue, right? And so the big thing with MS is you're going to want to make sure that they are, we're going to want to prevent those exacerbations, of course, and stay on top of the symptoms of, your typical MS, depending on what type of MS they have, which is another rabbit hole, but we won't be tested on it, just knowing that there are different types of MS, like relapsing remitting, progressive remitting, I don't know, just different types where sometimes it gets worse and worse and worse and worse to the point where the person just cannot physically, their body is so weak that it can't send signals out effectively from that central nervous system out to the peripherals. MS is a disease that is chronic, you just have it and you almost don't want to make it get worse. That's kind of what treatment is centered around, is not making it be worse. Sorry, you're probably hearing me put on chapstick because for some reason, even though it's 71 degrees out and it's been great weather, my lips this morning were looking like the top of one of those cracked dry deserts. I'm not even kidding. I've never had that happen before. Ashy lips, that's disgusting, by the way. Ashy freaking lips. Hey, I thought I'd never see the day, and the day came. The day came today, and I was like, oh, I gotta be drinking water, and I got my DCT on, okay? We are not playing. Anyway, GBS is a little different. GBS is a sudden thing that happens when the peripheral myelin sheath, made up of Schwann cells, okay, the cells are different. The ones in the CNS and the ones in the PNS are different, okay? And the GBS, the Schwann cells, which make up the myelin sheath in the peripheral nervous system, are being messed up, right? So the big thing you'll see with GBS is ascending, sometimes descending, but mostly ascending paralysis. It's a flaccid paralysis where the person can just literally not move those limbs. Okay, they literally cannot move them, and it's ascending. So starting from the bottom of their toes, you can go all the way up, and that person will not be able to move, which puts them, of course, at risk for lung problems, issues breathing because they can't move their diaphragm, and so their tidal volume goes down. They're at risk for aspiration. There's a potential that they could have trouble swallowing. Any sort of those muscles that help with those very vital functions. This person is at risk for nutritional issues. Not to mention the fact that they're going to be in bed all day, so they're putting them at risk for pressure ulcers. So a lot of issues that can happen here, impaired elimination, blah, blah, blah. The good thing about GBS, right, is that if it doesn't kill you, you can get over it. There's an acute phase, which is 1 to 4 weeks or something, where it just the paralysis gets worse and worse, and eventually it plateaus, where the paralysis doesn't increase anymore, but it doesn't get better, and then it goes from that plateau then down to the recovery phase, where some people will recover like they never lost anything, and other people, they'll have residual symptoms just because it was such a strain on their body. But overall, that peripheral nervous system can slowly start to build back a little bit better. Whereas in MS, multiple sclerosis, it's a lot more. It is chronic. So once the myelin and the osteo, what are they freaking called? goodness gracious. Hold on. Oligodendrites. There we freaking go. So once those oligodendrites start dying, you can't really get them back. So that's the issue with MS. Whereas in the PNS, there's a chance that they can sort of kind of regain some function. Maybe not all function, but some function. So GBS is one of our only acute neuromuscular issues. That brings us to our next two neuromuscular problems, myasthenia gravis, also known as MG. It's kind of rough that MG and MS are together because, when they both start with M and then another consonant, you're like, man, how do I keep these differentiated? Okay, so myasthenia gravis, okay? Gravis, like gravity, okay? When you think of gravity, you think kind of heavy, something pressing down on you, this external force that's making it hard to move, right? Because if gravity was low, you could just bounce all over the place, whereas, the gravity that we have, 99.81 meters per second squared, that's too much. we can't fly with that kind of gravity. So what myasthenia gravis does, it is this progressive fatigue, okay? And it presents as this incredible fatigue that makes it hard for your body to keep functioning, simply because you essentially get tired. Now let's talk about it. This has to do with neurotransmitters. Now, we talked about neurotransmitters a little bit, like a tiny bit, in the last lecture when we were talking a little bit about like the pathophysiology of what a neuromuscular disease is. We talked about how there's a lot of things that help our bodies move and do things, right? And one of those things are neurotransmitters, okay? We talked about how neurotransmitters, like the signal comes down from dendrite? Yes, it's the dendrite. I don't know why I have this brain fog. I had some coffee, I had water, I don't know what's wrong. Anyway, dendrites, then signaling down to the axon, where now you have the other connection, okay? Now, these cells aren't necessarily touching. Let's not think about it like that for a second, okay? Between these two nerve cells is a bit of a gap. They call it the synaptic gap because there's synapses, okay? And in this gap, in this synaptic gap, are a bunch of freaking hormones or whatever and neurotransmitters. Now, hormones take a while to get there. Neurotransmitters, they're right there. They're ready to rock and roll, okay? Now, normally, when our body's like, okay, let's do a move. Let's do this thing called moving. Acetylcholine, which is, she's a mover and she's a shaker, okay? You don't stop acetylcholine. She says, we're going. We are running. And that means running with our legs. That means maybe our nose is running, okay? We are moving, we are grooving. Acetylcholine is there to help get us to move, okay? Now, remember how, like, if you have depression, all right? Now, this is going to sound like a side tangent, but I promise it's not a side tangent. You remember how, like, when you have depression, the issue here is that there's not enough serotonin, okay, that's being or is it that there's not enough? No, yeah, it's just that we don't have enough serotonin, okay? We are losing serotonin because it's not being brought back in. It's not being reused. It's just essentially being, like, left to sit around. It's left to sit around. So the whole point, right, is that serotonin reuptake inhibitors say, okay, well, we need more of a population of serotonin in that synaptic gap, okay? Because the reason you get to the depression is because you don't have enough serotonin. All right, serotonin is like a little happy hormone. It keeps you happy and it keeps you at a kind of homeostatic happy level, okay? Dopamine, same kind of deal, all right? Those are all kind of things that hang out here. Acetylcholine works a little differently, okay? And the reason that you have myasthenia gravis is doesn't mean necessarily that you're, need an acetylcholine reuptake inhibitor, okay? That's not the problem here. Is that for some reason your immune system has looked at your acetylcholine, this pretty important neurotransmitter, and it says, he's the enemy. We have to kill acetylcholine. And all the other immunoglobulins and modulators, they look at each other and go, what? And And this rogue antibody, he goes, yes, you'll never believe it, but acetylcholine has been the one pulling the strings this whole time. Remember that one time that we walked in a crowd and got sick, and all of the immune cells, they look at each other and they go, maybe, I don't know. He's like, it was because of acetylcholine. And so they've developed this coup where now they are here and they want to destroy acetylcholine. Now, unfortunately, this is this is not good, okay? Sometimes the immune system gets it in its head that things that belong in your body really don't belong there, and that's where we have a problem. So these antibodies are going to attach to the acetylcholine receptors. They attach right there, okay? And they attach right there to block the uptake of block the transmission of the acetylcholine. So there's plenty of acetylcholine in here. The problem is, right, that we aren't getting acetylcholine to actually move the signal, okay? This is a peripheral issue because here, perhaps this nerve said, yeah, let's freaking go. Like, I'm ready to move. Like, this will be perfect. And unfortunately, we can't bring in the acetylcholine we used to be able to get in. So now this neuron, the telephone chain has been broken, okay? This neuron says, yeah, let's move. And so acetylcholine is like, okay, but I don't have anywhere to go. I don't know where to go. What the heck? And so, unfortunately, the signal isn't moved forward. And so even if you want to move, you can't, okay? Now, with myasthenia gravis, it's not as if you couldn't move necessarily, right? But as it progresses, as throughout the day, even, you're blocking this stuff, your amount of acetylcholine that you can use goes down because it's meant to be gone from here, reuptook. It's not, so it's just sitting around doing nothing because it doesn't go anywhere, which is kind of rough. Hey, what the frick? Why'd that go down? I guess I did it a while back. Anyway, I want to check that. Is acetylcholine taken in myasthenia gravis? I don't think that's, you know what, whatever. But acetylcholine reuptake is not directly affected. Okay, cool. Triggering muscle contraction. So reduction of the number of functional of the receptors at the neuromuscular junction. With fewer functional acetylcholine receptors, the muscle receives fewer signals from the nerves, resulting in muscle weakness and fatigue. So I guess it's kind of like how in MS, the signals, you need a higher threshold of signal, right? Because neurotransmitters directly affect how much signal required to move, right? Remember the action potential, where there's that certain threshold where your body the signal has to get to in order for the body to end up doing that. And the reason that there's so much fatigue in MS is because you have to do a lot of stuff in order for that movement to happen. More stuff than you should have to do. And you just get tired because your body is using a lot of energy to send these signals. A lot of energy. I mean, a lot of your brain consumption of your consumption of calories comes from your brain. Like it's a good solid percent because your brain is constantly using using ions, constantly needing food, so as it were, to continue to function. So as it's working really, really hard, you're going to get really tired because your body's like, hey, we don't have the stores for energy that we need to continue moving like this. And it works really similarly with myasthenia gravis. However, the difference here is that it's a neurotransmitter problem. The signal is moving just fine. It just can't get through to the next nerve cell as well because we don't have as many of these receptors that help bring in the neurotransmitter that help the action potential. Doesn't happen the way we want it to, which kind of sucks. So, the important thing to remember about myasthenia gravis, okay? This is not a problem with a myelin sheath. Here, you're going to see small muscles affected first, okay? So when you think of small muscles, what do you freaking think of? Okay, well, we could think of maybe the stuff in the eye, in the mouth, because you look at the face anatomy, muscles. There's a lot of stuff here, but it's little muscles. I mean, this little guy, the zygomaticus, he's a little guy when you think about it. When you compare him to like the gluteus maximus, you know, not great, right? You're looking at all these tiny, tiny little things. Those little guys are gonna get tired. They're not used to moving as much anyway, and then the amount of stuff you're doing with them, I mean, man, it gets you tired. So remember, for myasthenia gravis, something that can just help differentiate it from all the other things, smaller muscles will be affected first. Whereas in MS, it really doesn't differentiate, right? Because it's central. It's a central nervous system problem. You'll see the sensory issues. Here, so far, we haven't really talked about necessarily those sensory muscles because it's not a CNS problem. It's a PNS problem. So everything else peripherally, right? Those outside muscles that aren't attached to, a whole lot, they're the ones that are going to be getting this tiredness, okay? So some more symptoms. Eye muscles. So eye muscles right there are going to get tired. You're going to maybe see one eyelid droop or two eyelids droop. You might see double vision because I want to know why. Why double vision in MG? The disease weakens the muscles that control eye movements, leading to misalignment. So the difference here, right, is it's not a CNS problem. It's not necessarily a sensory issue. The issue here with the double vision is that those eye muscles, the ones that come right there, they're not able to control very well, leading to the eye kind of sagging away. So you're seeing here, maybe because the eye is right there, so you're seeing there with one eye and straight ahead with the other eye. So you're going to have a distorted image of what's happening in front of you. That kind of is crazy, actually. But yeah. Whereas in MS, it's a damage to the nerves themselves, right? Here the nerves are fine. This is not it's not a myelin sheath problem. The nerves are chilling. The nerves are like, okay, I think I've got this. The issue here is the muscles. The issue is the muscles. I know they have facial nerves, 3, 4, 6, 5, whatever. But the issue with myasthenia gravis has never been necessarily, okay, the actual nerves themselves. They want to move that message forward. It's the neurotransmitter issue, okay? So, boom. Because you're not going to see any problem like with smelling. You're not going to see any sort of problem with hearing like you would see in MS. In MG, it is a muscle problem because the neurotransmitters themselves don't want to move the message. Boom. Kind of sucks. Difficulty swallowing, altered speaking. Why is that? Well, do muscles help us speak? The answer is yes. Yes, they're essential for speaking, okay? They move the vocal cords, tongue, lips, jaw, in the mouth and throat. So if you're tired, all your muscles are tired, and you want to have a conversation with somebody, me yapping, by the way, burning calories. Hey guys, this is gonna be crazy. This is crazy. You ever talk so much that your jaw hurts? No, just me. Okay. No, you talk so much and your jaw hurts, and the top of your cheeks kind of feels like tight, right? Well, that's because your mouth is tired. Now, imagine you just have a couple of sentences and then your tongue just feels so heavy you can't really you can't really use it to help pronunciate anything, right? So you might be able to make the sound with your mouth, but I don't want to, you know what I mean? You can't differentiate anything. And with that, if you've got any sort of tongue weakness, you're going to have difficulty swallowing. There's a bunch of muscles in the neck that are going to be essential for getting that down and swallowing and moving different things. Muscles in the larynx control the tension and position of the vocal cords, right? Because there's muscles in the larynx. Well, guess where food passes down? We got the oropharynx, the larynx, esophagus. So if you've got problems with those muscles, you're going to have difficulty swallowing. This person might be at risk for having aspiration for sure. This person is also at risk for having trouble breathing with that same tidal volume. As the day wears on, they're just going to be really tired. So, being able to even, like, if you wanted to breathe, having those intercostal muscles retract, if you were in a respiratory crisis, you wouldn't be able to. Your body would just be too weak. Problems chewing, same thing. Limited facial expressions, mask-like face kind of thing. She don't want to smile. She can't smile. I mean, she could try, but her muscles are just tired. They just don't want to do anything because it takes a lot of energy for them to be able to pass that action potential when there's not a whole lot of help from the neurotransmitters. Neck and limb muscles, you're going to have weakness in your arms, your leg, your neck, your fingers, in the chest muscles sometimes. And that can be really, really bad. That's going to be one of our indications for having that ineffective breathing. Because like I said, your diaphragm is a super important muscle when it comes to being able to breathe. It helps to help propel that air out and help to bring back air in. With that pressure in the cavity, like the lung cavity, is like essential to breathing. And if that pressure is not able to be, high enough or low enough, high enough to get the air out and low enough to get the air in, we're going to have an ineffective breathing pattern, which could put our patient at risk for a lot of things. Respiratory problems, respiratory alkalosis leading to acidosis, not good. If this gets really, really bad, right, if we're not able to breathe at all, this is what we're going to call it a myasthenic crisis. Myasthenic crisis. That's how I just sounded right there. So we'll talk about a myasthenic crisis in a minute. But essentially, this is life-threatening. A myasthenic crisis is when you get that ineffective breathing, essentially, and now this person is at risk for passing away. Airway, breathing, circulation, they've lost their airway. They've lost their breathing, and even though they've got space here, right, the air can get in, they can't really breathe it out. And that whole airway itself has almost become compromised because there's not a whole lot of muscles that can help anywhere here, right? Airway, breathing, circulation, we've got a breathing problem. We have a huge breathing problem. Yeah. Somebody texting me? What the heck? Okie dokie. Yippee. Dang. Anyway. Now, we'll move on because we'll talk about a myasthenic crisis and a cholinergic crisis in a minute. But how does a doctor diagnose this? Okay, well, so there's a couple of things that can that they'll do, but there's only one way of really definitively figuring out that this is MG, okay? So the first and definitive way for a doctor to figure out that there's a problem here is called a tensilon test. Now these symptoms, these could be there could be a lot of things. I mean, how do you differentiate this myasthenia gravis from kind of a bad case of MS, right? So here, the reason that the way this tensilon test works essentially is that they pump in a bunch of acetylcholine. Basically, they just give you acetylcholine, bam, right in your. I don't know. Is that a I don't know. Is that you know what? I'm gonna ask. What is a tensilon test? Procedure. They just directed IV. That's what I was looking for. Directed a small amount of edrophonium, which is a cholinesterase inhibitor, which essentially just increases the amount of acetylcholine in the neuromuscular junction, right? Bam, they pump up all that acetylcholine, okay? Immediately, right? It takes like 3 seconds. There's like a video where they did it to a dog. Same thing on humans. In a positive tensilon test, okay? They get this, and then immediately their symptoms, their muscle strength improved, all right? Their breathing improves. Everything improves, and it's almost like they're a brand new person, Okay? That is a tensilon test. If it's negative, it's not MG. Tensilon is a definitive, like, okay, this will only work to fix stuff if they have MG. It's usually not the first thing that doctors will go for, though. They will try a lot of other things to figure out what's going on here. They're gonna try giving atropine, which is an anticholinergic, right? Um, like, you know what? We'll leave that one for a second, because atropine is an anticholinergic, and that's really going to be given if you are having a cholinergic crisis. But we'll get to that in a second. AChR blood test, where they're looking for, because remember, antibodies are messy eaters, so you're looking to see if there are, and I want to check that, but I think you're looking to see if you can see the little mess of the AChR blood test. Yep, antibodies in the blood. Measure of acetylcholine receptor antibodies in the blood. So if you've got these, there's a chance you might have MG, because your acetylcholine receptors, they're sitting there. If it comes in the blood, that means they're being moved out. They're being moved around. Electrophysiologic tests. I don't think the electrophysiologic test will really see anything. For diagnosing, the tests assess neuromuscular transmission, measuring the amplitude of the compound muscle action potential. Okay, so they're just checking to see here how well your muscles move, essentially. Especially in patients who are seronegative. So if they don't have detectable antibodies, they can kind of use these to figure out what's going on. Test the severity of MG and differentiate it from other neuromuscular disorders. Okay? Neuromuscular transmission via nerve conduction velocity and EMG, electromyography. Yep. Electrical activity in muscles and nerves. Yeah, anyway. Thyroid function test. Why would they do this? Because they want to make sure that this isn't a thyroid problem. Now, they're looking for TS3 and TS4. The thyroid gland tumor, if you have a thyroid gland tumor, it can cause MG. It can cause myasthenia gravis, and for some people, if this is removed, now it's not like a lot of people. I think it's like a very small percentage. But if by chance this thymus tumor is causing your MG, getting it out is nice. It's good. It's really nice to get this out. And since this thymus is like essentially in your throat, like the lower part of it, of course, if your patient is getting this removed, breathing is going to be huge, and airway is going to be huge, making sure that that's not compromised after the surgery. But whatever. And then CT scan of neck and upper mediastinum to check and see for that tumor what's going on. Myasthenia gravis medication. So, they have this thing called pyridostigmine and prostigmine. How do those help? Because they do. Let's see here. Pyridostigmine is a reversible cholinesterase inhibitor that works by increasing the availability of acetylcholine at the neuromuscular junction. So it's really similar to this edrophonium stuff. And the whole point of it is it's essentially like it stops acetylcholinesterase, which is the enzyme responsible for breaking down acetylcholine from working. Okay, so that means that yes, even though those sites are still hurt, right? Those sites for the acetylcholine receptors are still hurt. If you've got more acetylcholine, right, then it's like, okay, well, some of it won't get in, but a good chunk of it will. So it's almost like you're making up for the extra sites that are lost, because your body's the signal needs to get through, and your body goes, oh well, it's okay, we'll just pump more acetylcholine into the receptor that's still working. So having that acetylcholinesterase is really nice, or having this pyridostigmine that gets rid of the acetylcholinesterase by just binding to it, basically saying no, you can't go. We got a little bit of extra acetylcholine. Now this is good, right? But remember, we've got a lot of this acetylcholine. What if we have too much? Because acetylcholine isn't just this beautiful, lovely neurotransmitter that never hurts anybody. Acetylcholine can be really, really dangerous if we have too much of it and it can't be gotten rid of, right? We have acetylcholinesterase for a reason, and when we take it out, it puts us at a risk for a cholinergic crisis, which we'll talk about in a second. This other person may also receive immunosuppressants, because remember, this is an autoimmune problem. Our immune system has looked at our acetylcholine receptors and said they're the villains. We have to kill them, get rid of them. And unfortunately, what we have to do in this case to prevent myasthenia gravis from getting worse is put this person on some immunosuppressants, which would be IVIG, right, to help to just kind of inhibit that immune system. Or this person may also receive a plasmapheresis, maybe to hope to get out those nasty autoantibodies and replace them with nice ones, right? Now for education, this person will still for a very long time be able to live a pretty, a decent life. The issue, of course, with myasthenia gravis is that your life now runs on a schedule of when you take these medications. Because this acetylcholine won't last forever. Eventually it will need to it will be used, quote unquote, right? And once it's used, you're going to get real tired real quick, right? So anything you can do to conserve energy is important. Resting is important. When it comes to caring for these patients, clustering care is really, really important. You don't want to tucker them out, right? If they desperately need physical therapy or something, the physical therapy people got to know that they have this, which they usually will, but you also want to make sure that this has happened, like once they get their medications, once they get their dose of pyridostigmine or prostigmine, which we'll see if the prostigmine stuff is different, works as a reversible cholinesterase inhibitor. Okay, same thing. They literally do the same thing. So, once they get this, they're going to have that energy that you need. That's when you want to do stuff for them. All right? That's when they might want to move from the bed to the chair. That's when they need to be eating breakfast. Maybe, that's when they need to want to go to the restroom. Like walk to the restroom, for their own sake. Whatever. Put them on the Serosteti, get them there if that's part of their daily, if they're in the hospital, right? Plan care, because these people can get real tired real quick. So assistive devices are important. Medications, you have to give them on time. They are on a schedule. And if they don't get their medications on time, they get real tired. And remember, there's that risk. If they're not getting their medications on time, we don't want this crisis to occur where they can't breathe anymore. We don't want that. Sounds awful. Let's not do that, okay? Worse even, right? Even if they're not in a crisis, if they haven't gotten their medications, they may be too tired to swallow. We do not need them aspirating on their medication because, oops, well, that was a mistake. I didn't think that I couldn't give it on time. Well, we should be giving it on time, by the way, always. But this is a particularly important medication to make sure this person gets on schedule, right? And once you get that schedule, especially if you know they have MG and they have a lot of things they need to get done with, or they've got a lot of they need this so that they can swallow their pills, so that they can do what they need to do. Eye care. Now, one thing that can happen, right, is that not only do we have that double vision, but their eyes get really tired, right? Some people will even have to tape their eyes open in order to see. So things to think about there. It's not so much that they maybe need eye drops because their eyes are always open, right? Maybe for somebody who has Graves' disease, but no, it's for here. This person's going to be real tired. Look at that. Their eyelids are literally so tired they can hardly hold them open anymore. So things to think about. Meal planning, best to eat after taking the med, and take foods that don't take excess chewing. So this person doesn't need pureed foods, but they definitely shouldn't be smacking on I don't know, a what's crunchy, dude? What takes, what they shouldn't be eating? They should not be trying to eat those like taffies. The real, like the authentic ones, dude. Authentic taffy, I'm sorry, you're never chewing that. You almost have to swallow it after some time and just hope it doesn't get stuck in your freaking throat. That stuff is so thick, I can't even don't even get me started. Okay. Myasthenia gravis crisis. So, crises are not good. When you see the words crisis, bad. We don't like crises. We want everything to be fine and good all the time. Yeehaw. Well, so here's what happens in a myasthenia. If you're under medicated, so let's say you just haven't taken your pyridostigmine. Maybe there's an issue where you haven't been able to leave the house for a while and you've run out of pyridostigmine, or maybe there's an insurance issue, blah, blah, blah. You don't get your pyridostigmine. So now these acetylcholine issues get worse and worse, and eventually you get to a point where you literally can't do anything anymore. If you can't breathe, you will die. Hate to say it. So, in a myasthenic crisis, you have to be able to do your thing, okay? Very, very important. And they have this little way of remembering stuff here. I think I wrote it down here. Yep. So, in a myasthenic crisis, okay, you can't see, your eye muscles ain't working. In fact, your eyelids are pretty much closed. You can't see, you can't pee, all right, because everything is closed up. You're not doing anything. If these are all your muscles, you're not doing anything. The muscles, the smooth muscles of your your ureters, they're not doing a single dang thing. Can't spit, saliva production, nope, gone. By the way, sorry, goodbye, because saliva production is predominantly kind of regulated and done through the acetylcholine, which is what we're going to talk about in a cholinergic crisis. It's very important to consider. And then you can't poop, you can't spit or shit, you can't do it because, hey, smooth muscle, guys, smooth muscle, you don't have the acetylcholine you need. Constipation sets in hard, right? So if you can't see, okay, well, that's safety, first of all. Can't pee. Well, now we're at a risk for having a freaking acute kidney injury. If you can't pee, that stuff is just building up in there, and your kidneys are like, hey, get this out. Worst case, as well as having these waste products build up because they're just like, well, we have to put this somewhere. Can't spit. Well, okay, if you can't spit, you're not making your saliva. That's not good anyway. Your saliva is really important with keeping your teeth clean. So here you're looking at dental caries potentially. And you can't poop, can't shit. Well, hey, that's not good either. We don't want an obstruction in your colon because now how are you, that's nutritional problems, that's painful, that hurts. And also, that can cause necrosis of the tissue if it's stuck in there for too long. Myasthenic crises are not good. They are not good at all. And on top of that, you're going to have trouble breathing. So the big thing that you'll need to do here with this myasthenic crisis is get them back on their medication. Get them their medications, like slowly but surely, they will come back up to a middle. Now, what if you give them the medication and then, of course, the thing that happens, and it can happen, it happens with the thyroid, what has happened is it's overcompensation. So let's say we freak out. Okay, this person is coming in with a myasthenic crisis. Now they got all the acetylcholine. They got so much acetylcholine it's coming out of their ears. Well, in a cholinergic crisis, you have all these. Look at this. It's the opposite. Okay, kind of. The seeing doesn't really come into play. Okay, bradycardia, bronchospasm. Bradycardia and bronchospasm. Why is that? Why bradycardia in cholinergic crisis? Because of the overstimulation of muscarinic receptors by excess acetylcholine, which leads to increased parasympathetic nervous activity. Whoa, that sucks. Whoa, that's so sad. Wow, that's really, really sad. So essentially, this cholinergic crisis is this big parasympathetic issue. So it's like your body is like, hey guys, resting and digesting? How about we do that times 1,000? That sucks, brother. That really stinks. So resting and digesting. So your heart chill out. Not we don't need that. Bronchospasm. Now why bronchospasm? Mm-mm-mm. Okay, in the constriction of the smooth muscles lining the bronchi, resulting in difficulty breathing and wheezing. Oh, cool. That's nice. So whereas before we weren't able to actually use those muscles, now these muscles are being 100% used. They're like, yeah, let's freaking go. We got all this acetylcholine. Let's do it in our bronchioles. So now you have problems breathing and wheezing because your bronchioles are so constricted that it's like you're having like an asthma attack kind of a thing. Salivation, remember we talked about how acetylcholine stimulates saliva production? Yeah. Lacrimation, tears, saliva and tears. Those are all acetylcholine problems. Hey, guess whose fault that is? Urination. Hey, resting and digesting means peeing too. We're going to have urination, diarrhea, GI cramps. Our body is like, we literally cannot keep this up. And the acetylcholine is like, did I ask? Now keep pooping. Yep, that's exactly what happens. And then emesis. Emesis is interesting, and I think it probably has to do with probably some extra spasming of the freaking tract. Yeah. Yep, there it is. We literally called it. I didn't even look at that, by the way. When that popped up, I didn't look at it because I didn't want to see it, but yeah. So your bronchial spasming, gastrointestinal tract spasming, and then eventually this puts the patient at risk for hypertension, and I say because all your fluids are in the toilet. It sucks. So here with myasthenia gravis, the point is to avoid either of these. These are bad. We don't want either of them. So we want to make sure that they keep their prescribed drugs, glass of water close at bedside, like right there, so that as soon as they wake up, they can just reach over on their bedside, grab them, and start their day. Wear a watch with an alarm to remind you to take your drugs. Take your drugs on time. Post your drug schedule so that others know it, whoever that needs to be. If that's an employer, if that's your family, if that's your friends, they need to know that during this time you need to have your drugs. Plan strenuous activities when the drug peaks at its best point of action, right? So that by the time that point is done, you've done all the hard stuff. So now you can actually start to rest. Keep an extra supply of drugs in your car. Be sure they are secure. Do not run out of these drugs. If you ever do, you're in a world of hurt. Truly. They need to make sure that these drugs you have some just in case. At all times you need some. Do not take any over-the-counter drugs without checking your healthcare provider, of course, because we do not want any adverse medication reactions to each other. So here's just some the same things. So yeah, we have 2 more things to go over, I believe. And it's 5:45, so we may have to come back to this later, but let's talk about rheumatoid arthritis. Now, rheumatoid arthritis, there's not a whole lot of stuff in here about because it's literally 2 things. So freaking sad. Oopsies. So, rheumatoid arthritis. So, the big thing with rheumatoid arthritis, okay, is that it is caused by it is an autoimmune disease triggered by some sort of other disease, okay? And when this other disease pops in, like, I don't know, the Epstein-Barr virus or something, the body kind of freaks out and it looks at this joint, the synovial tissue of the joint, and says, okay, you're the enemy, let's kill him. Really awkward. And that's because these microbes really like joints. They love joints. They love to just sit in joints and enjoy themselves. And when the antibodies come in, they go, oh, there they are. They're the evils. So that they come in here and they just mess up this whole joint tissue. Well, unfortunately, that joint tissue is really important for keeping our bones happy, for keeping us out of pain, and for keeping our movement smooth. So when these are destroyed, right, eventually it starts here at the joint, but it can cause bone erosion. erosion, okay, and a lot of pain, okay. Some things to know about rheumatoid arthritis, okay. Um, it oftentimes, I mean, it'll present symmetrically, okay. So this is not just a one joint thing. In stuff like osteoarthritis, sometimes it's just you've used a joint way too much, or there's just been this progressive degradation. So with osteoarthritis, you may have unilateral symptoms, like you have it on one knee or on one side of your hip, right? So you just replace that hip and you're cool, right? On rheumatoid arthritis, in general, you're gonna have it probably on both sides. You're gonna have it, in your, you'll have it in your smaller joints. They have this big one here, but you're gonna have it in your hands. You might have it in your wrists, your feet, and your knees, right? So it's gonna be in those other places. You might not have it in your hips, whereas in osteoarthritis, it does generally have to do with maybe overuse and bad nutrition, right? So it could be anywhere, but overall, it's gonna be maybe in one place where there's a combination of those two factors. In rheumatoid arthritis, it's going to be usually on both sides. Think about it as symmetrical as much as possible, right? It can be otherwise, but usually symmetrical. Okay. Pain with rheumatoid arthritis is going to be worse in the morning, I believe. I'm going to check that because I don't want to be wrong and be completely silly and goofy. Oh my goodness. I have to sign into Canvas again. That's so annoying. Here we are. Here we are. Okay, we wrote a great question and it has a bunch of the stuff in it. So, here we are. Here is the, that right there is the rheumatoid arthritis thing. Symmetrical joint pain in wrists, hands, feet, knees, worse in the morning. And we'll talk about the lab values in a second and which those are. But essentially, in the morning. So I wanted to check I wasn't crazy, okay? So more symptoms. You may have fever, okay? Because it's an infection. It was the precursor for this is an infection, generally. You're going to have fatigue, just simply due to potentially any infection, but also you're not going to want to move. It's going to be painful. Weight loss. And I want to check why. Why weight loss in rheumatoid arthritis? A body's response to chronic inflammation would be reduced appetite and decreased physical mobility. So, I mean, since you have a bunch of pain, and in chronic inflammation, your body's just like, listen, hunker down, don't do anything, which is awkward that you're not hungry because your body is so inflamed that it just can't even think about that right there. But anyway, anemia. Hey, why anemia? Chronic inflammation can lead to iron deficiency because RA's chronic inflammation can reduce the production of red blood cells in the bone marrow. Oh, if this area is all inflamed and the bones are producing stuff and they're like, well, there's so much inflammation, we don't want to do that. That could do it. Nodules into the skin, something like that. A little bit of a nodule there. Eye inflammation. Would that also just because it's just kind of this chronic inflammation problem? And then lung problems, which is RA-associated lung disease, which is great, but we're not going to talk about that because what we're talking about here is rheumatoid arthritis. There's all other types of rheumatoid problems, but here we're just talking about the bone problem, or the joint problem, I guess we should say. Rheumatoid, which I think rheumatoid has to do rheumo prefix to flow. So it's joints. It's joints. Which is why rheumatic heart disease, it doesn't have to do with the heart muscle. It has to actually do with the the connective tissue in the heart, in your oh my word, your valves. Yeah, yeehaw. Anyway, symptoms of RA can vary in severity and may come and go in flares, where some people may have like mild symptoms and other people will be in debilitating distress. Anyway, yeah, so there's blood tests that people can do, and we'll look at those. Labs. So the big thing with rheumatoid arthritis, I think I've said that like 4 times. There's this thing called rheumatoid factor, which is an antibody that a lot of RA patients have. Because remember, this is an inflammation of the joint, okay? And the immune system is coming through here. They see these nasty viruses or whatever proliferating in the connective tissue, because they really like the connective tissue, and they all go, attack, get in there, and they start to destroy that tissue, okay? And they're creating antibodies against that tissue because that's where it's housing the viruses, right? So you'll see this rheumatoid factor in the blood circulation, okay? Just like we would see that acetylcholase antibodies to the acetylcholase receptors floating around in Myasthenia gravis. Yes, that's correct. I said that correctly. Okay. You're also going to see C-reactive protein, which is an inflammation marker, which you'll see with a lot of stuff, but it has to do with specifically inflammation. You'll also see erythrocyte sedimentation rate. I think that goes down, right? Because you're going to be levels in... I think it would go down because it's a test measuring inflammation. Okay, so then it would be up. The rate at which blood cells settle in a test tube, a higher rate indicates a greater presence of inflammation. So ESR would be up, C-reactive protein would be up, and then you're going to see an antinuclear antibody ANA test to indicate RA. They might look at your joint fluid to see if there's any nasty things in there. Yeah. Cool. So, yeah, it's an autoimmune disease, so they're going to be on some they're going to be on anti-inflammatories, okay? Yeah, they're going to be on anti-inflammatories. But let me see. Would you use immunomodulators for rheumatoid arthritis? Yes. So that's what I wanted to say it, and I was like, maybe. So yeah, you're going to be using immunomodulators, immunosuppressants to help to suppress the immune system, to help control that immune response so that your antibodies aren't just coming in here and wreaking havoc on your joints. Anti-inflammatories are your first line of defense for both pain and that inflammatory response. Aspirin and NSAIDs, not Tylenol. Tylenol will not really work at all. In fact, it basically won't. Yeah, it doesn't help much at all, especially for pain. And the reason for that, I looked it up because I was like, well, because the way that acetaminophen works is that it inhibits the COX-2 enzymes, COX-2 somethings, in the central nervous system. Now, COX-2 is an inflammation marker. And I was sitting here and I was like, well, wouldn't that make them anti-inflammatory? Yes, yes question, or yes asterisk. They work in the central nervous system, okay, which is the brain stem, okay, and the spinal cord, kind of ish, not really, okay, brain and brain stem. Essentially, acetaminophen makes you more blind to pain. It's not like the pain response isn't getting there. It's just stopping the inflammation in the central nervous system, okay? So yes, it can help with pain, but usually it has to do with that only in the central nervous system. Whereas NSAIDs, because they also inhibit the COX-2 deal, okay? But the difference there is that it is peripheral. It is in your actual joints, in your actual bones and muscles, and so you're starting to parse down that inflammation, which is helping the pain response. That is how NSAIDs work, and that's why NSAIDs are the treatment that is preferred, like right off the bat, for something like rheumatoid arthritis. Okay, can help with the pain and the inflammation. That is a double whammy, and those are going to be big things that somebody with rheumatoid arthritis needs to have controlled. Now, another one that is given specifically for rheumatoid arthritis are DMARDs, disease-modifying anti-rheumatic drugs. Look at that. Anti-rheumatic is literally in the name. What a fun time. And the big one here is hydrochloroquine and etanercept, okay? Now, hydrochloroquine, that's a great drug, okay? Yippee. Hydrochloroquine, I want to check this, but I think it can, like, screw up your eyes. Yep, can cause retinal damage. Oh, thanks, hydrochloroquine. So this person, I mean, if their disease is like really, really bad, because this is chronic as well. Like, you're gonna have this, you're gonna deal with it for a while, if not ever. Hold on. Can I get rid of rheumatoid arthritis? The answer is going to probably be no cure. So you may be on this for a really long time, right? They want to start you off on NSAIDs and hopefully control it. But if that gets really, really bad, the doctor may prescribe you hydrochloroquine. Now, the one thing with hydrochloroquine, that's great. If it's working, that's awesome. If you ever start to have like dots in your vision, you're seeing like a lot of floaters, maybe you're kind of weird light flashing stuff, they're going to stop hydrochloroquine. They are not going to cause that retinal damage and vision loss. I mean, I guess if you, like, as the patient were like, no, keep me on it, I will go blind. Okay, sure. Okay, sure. But unfortunately, the risk of retinal damage increases as the dose goes up. So, I mean, we'd rather just control it with NSAIDs and hope that things go down. But if a person is taking hydrochloroquine, it may work. But if there's ever any retinal damage, the doctor's going to be like, we need to stop this. Let's stop it right away. Etanercept. I'm trying to think if there's anything. I mean, it's blocking TNF, sub-Q injection. Anyway, that can also be used. Prednisone. Steroids are huge, right? Steroids are like the ultimate in fast-acting anti-inflammatory. They go, oh, you have inflammation? No, you don't. No, you don't, idiot. So a big one, especially for exacerbations of rheumatoid arthritis, steroids, like prednisone, or like methylprednisone, or whatever. Steroids. Yippee! And then a person with this may get plasmapheresis as well. And I think IVIG used for rheumatoid arthritis, ? Can be safe, blah, blah, blah. It's not a first line, evidence is mixed. So here we'll just say plasmapheresis. If we're not sure, we'll just say plasmapheresis, because that's the only thing on the slide. Usually, when we are talking about plasmapheresis and IVIG, at least on these slides, it's been like plasmapheresis or IVIG. Here it looks like it's mixed, so we'll just go with plasmapheresis. We have one more thing to go over with, and it is fibromyalgia. Yippee! Fibromyalgia! Actually, fibromyalgia sucks so much. Fibromyalgia, they have it here described as chronic central pain syndrome. Hey, that sounds awful. I don't want chronic pain as a syndrome. If it's central, doesn't sound great to me, okay? And the way that it presents is with widespread non-auricular musculoskeletal pain. Hey, what does the word non-auricular mean? Articular means relating to soft tissue such as muscles and connective tissues rather than joints. Not a joint problem. Okay, guys, we figured this out. Not a joint problem. It is specifically a muscle problem. I hope you didn't hear the sound of my spit. The sound of my spit just like kind of trickling down. That's actually disgusting. I'm going to stop. That's actually so gross. Fatigue. Hey, sure. Hey, listen, I'd be tired if I was in pain all the time in like specific points in my body for months. Multiple tender points, and we'll talk about it. You have to have at least four different parts of chronic pain for 3 months. And we'll talk about that more. Women are two times more likely to get fibromyalgia than men. Women, I suppose. So it has to do with an abnormal central processing of pain. And unfortunately, there are like a bunch of different. Look at all of these. What the crap? So pain is kind of weird. There's like a bunch of research into inflammatory responses and whatever, but pain is a little bit more complicated. Why is it that some people experience pain differently than other people? You know, why do some things cause pain? Why do some things not cause pain? It's a little bit complicated, okay? And we can talk about that, but I would love to see fibromyalgia, pain. You know what? Patho. Okay. Here, I'll just read what they have here. I will say they're usually pretty good. As much as this AI overview is an AI overview, they basically just plagiarize. You'll take it here and you'll like go straight to the link. Like if I was to go straight to the link right here, you could probably find this exact thing right there. I'm not even kidding. I looked at it one time. I was like, oh, that's exactly the sentence. But they do have their little link there, so whatever. Thought to involve a complex interplay of central nervous system alterations, including dysregulation of pain pathways and neurotransmitters, leading to increased sensitivity to pain and other symptoms like fatigue and sleep problems. Fibromyalgia is now viewed as a disorder of central pain processing, with the brain and spinal cord exhibiting heightened activity and increased sensitivity to pain signals. They experience pain differently and their pain thresholds are lower, suggesting an altered way that the nervous system processes the pain signals. There's also a dysregulation of neurotransmitters such as serotonin and norepinephrine that contribute to the pain and other symptoms. So, you can look at all these different theories of pain. They have the specificity theory. I put the emphasis on the wrong syllable, and I'm not going back, by the way. Proposes that specific pain receptors transmit pain. Okay. Intensity theory suggests that pain is a function of intensity of noxious stimuli. Pattern theory proposes that it's a specific pattern of neural activity in the spinal cord and brain. Right? Explains how non-painful stimuli can modulate pain perception, like rubbing a sore spot. Okay. Gate control theory, which happens at the actual spinal cord level, where non-painful inputs like rubbing or distraction can close gates, quote unquote, blocking pain signals from reaching the brain. That one in this case would not be related because fibromyalgia is a central processing of pain issue, which means it's happening in the brain directly. Neuromatrix theory proposes that the brain creates a neuromatrix that generates pain perception based on our problems, based on us. Explains how pain can be influenced by psychological factors, and then biopsychosocial model, which is comprehensive, of course. Anytime you see the word biopsychosocial, think of it as kind of like, I don't know, TLDR, too long didn't research. Listen, it's very much like broad. They essentially go, well, multiple things can be correct for multiple reasons, which is great. Listen, I'm very much a proponent of nature and nurture, okay? And biopsychosocial is a lot of that. But anytime you see it, it's like there's a lot of things involved, and it's not specific, though. It's kind of, I liked, you know what? Haters are going to say that biopsychosocial is better. I would say it's the coward's way out. Sometimes it's not just that. Anyway. Chemical theory proposes that pain is the release of certain chemicals in response to tissue damage, like prostaglandins, which explains why some medications can do stuff, and then fear avoidance, blah, blah, blah. Now, lots of different patterns, lots of different theories. The point here is that fibromyalgia is a central processing problem. It is a brain problem, okay? Because you can see these PET scans, okay? PET scans will show the widespread neural inflammation. It's in your brain inflammation, okay? This is not inflammation in the body. It's the brain's problem. The brain is for some reason being like, everything hurts. The person is at increased risk for fibromyalgia if they have, what the frick? SLE? Oh, systemic lupus. We haven't talked about lupus yet. LOL. We're talking about lupus next. Systemic lupus oh my freaking goodness. Give me a second. Give me a second. Erythematosis. You know what? Too tired. Too tired. Osteoarthritis. So, increased risk. And, yeah, I'm not a scientist, by the way, but these are all inflammatory disease processes, right? And there's something to be said, right? If your brain has a pattern, it's constantly generating these pain perception inputs. There's a chance, like if they have that pathway memorized. Okay, they know exactly where to send those pain signals. And if they're at a risk they have all these things, or they've had them, they're dealing with them. There's a chance you could just get fibromyalgia because your brain is ready to pump the pain signal at any sort of time. And infection can also trigger it. So Epstein-Barr, unfortunately, Epstein-Barr virus, the proponent of so many of these, can trigger fibromyalgia. Now, we talked about how this pain needs to be present for at least 3 to 5 months, okay? In at least 4 regions, such as the shoulder, arm, jaw, hip, buttocks, leg, or axial region. And it can be on any side, okay? So this person's shoulder may hurt, their neck may hurt, their back may hurt, and their left leg may hurt. That's right. That's the right leg. I'm stupid. Left shoulder, right leg. If they have those that all hurt for 3 to 5 months, there's a chance they may just have fibromyalgia. Now, the pain for fibromyalgia is worst at night, okay? We talked about how in myasthenia... in rheumatoid arthritis, the pain is worse in the morning. Well, here in fibromyalgia, the pain is worse at night. And this pain can cause anxiety, mood swings. I mean, listen, I'd be moody if I was in pain all the time. And having those pain signals constantly, it's essentially like a sympathetic response all the time. That's what pain will trigger that. Your body is like, I'm dying. I'm hurting all over. What the freak is wrong with me? It's the brain. But here now you're going to have mood disturbances. They have here digestive issues, right? Now that your gut is confused, it wants to work, but there's pain that's happening, especially if it's like centralized here. So, yeah, not great. Let me see. Fibromyalgia GI effects. I spelled wrong effects, don't care. Abdominal pain, bloating, constipation, diarrhea. So yeah, your freaking stomach is confused. It's like, do we poo? Do we pee? It's kind of just the feast or famine, I suppose. Nausea, vomiting, diarrhea, constipation, bloating. Your GI system is very much in tune with your brain. And if you are in this sympathetic mess because you're in pain all the time, your GI system will follow. You may have pins and needles in your hands and forgetfulness as well. To differentiate from fibromyalgia from rheumatoid arthritis, they check for the sedimentation rate. Because in rheumatoid arthritis, let me check what this is. Sedimentation rate. That's ESR. That's inflammation. In fibromyalgia, there's no inflammation per se. It's in your head. It's all in your head, unfortunately. Kind of a bummer. So here they have best indicators for diagnosis, widespread pain index, talking about those different pain areas for at least 3 months, counting the number of points that hurt, and then blood tests, because it's all in the head. It's literally all in your head, and unfortunately, that sucks, all right? We talked about risk complications, blah, 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 blah. Treat with over-the-counter pain relievers, not opioids. The question is, why? Why not opioids for fibromyalgia? What the heck? Okay. While opioids are sometimes used for pain management in fibromyalgia, the current guidelines generally discourage their use due to limited efficacy and potential risks, including addiction and worsening fibromyalgia symptoms. Okay. Haven't shown traditional opioids are effective. Okay. Research suggests fibromyalgia and the chronic pain associated with it could worsen opioid use disorder because they have to use them. Blah 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 blah. Why don't opioids work for fibromyalgia? The underlying pain mechanisms in fibromyalgia are complex and don't involve a primary disturbance of the opioid analgesic system. Hold on. Opioid analgesics work. Binding to specific receptors in the brain and other parts of the body, which then alters the transmission of pain signals. Okay, bind to receptors, blah, blah, blah. Part of a larger known as the G protein coupled receptors. Causes a cascade of events within the nerve cell, including the inhibition of certain ion channels. Also carry risk, blah, blah, blah. Okay. Studies have shown that individuals with fibromyalgia have reduced binding ability to opioid receptors in the brain, which could mean fewer receptor modules or molecules are present. So they could be taking all these opioids, but only so many of them will actually be working, which means that their pain won't really and truly be controlled, and they're going to still be in pain, which sucks. And now they're also a chance for them to get addicted to them, which sucks. Fibromyalgia is considered essential sensitization syndrome, meaning that they are more sensitive to pain signals. Opioids, which can affect the activation of spinal glia that enhance pain transmission, may worsen pain in these patients. Hey, that sucks. That's so sad. So basically, no opioids. Opioids are not good. They can have NSAIDs, they can have Tylenol. Over the counter is what you got. Antidepressants to help to reduce pain and fatigue. Amitriptyline for sleep to just help them deal with it, essentially. And then anti-seizure meds to reduce nerve pain. And it's that nerve pain that's important, like gabapentin or pregabalin. So, yeah, here we are. Antidepressants, anti-seizure medications, NSAIDs, injections of steroids, lifestyle modification to help. We don't want to increase any sort of inflammation to increase the chance that pain pathway is triggered, right? Any sort of inflammation could trigger the pain pathway, right? So we would rather not have too much inflammation. They'll be getting injections of steroids, very likely though, and you can see here it doesn't have to let's see. Steroids for fibromyalgia are not recommended because of serious side effects. They may help with inflammation in the short term, but they're not effective for long-term pain management. Well, yeah, because at the end of the day, right, it's not an inflammatory issue, right? They might get these steroid injections to help reduce inflammation overall, but at the end of the day, it's a brain problem, right? So here where they're talking about exercise, controlling stressors, diets, limiting caffeine, sugar, and alcohol, those are all things that can increase inflammation. They make you more tense. And that same thing will trigger that pain pathway where now we have that sort of correlation to stress, inflammation, and pain, right? So no sugar, no alcohol, limit caffeine. I say limit caffeine, probably should be no caffeine. If there's ever a question, because the alternative is, well, if you need caffeine to wake up, you may just have pain because your body is like ready to rock. That caffeine is shooting through your veins. It's causing a little bit of trauma, and because of that, you may have some of that just inflammation. And then alternative therapies for pain management, massage, acupuncture, physical therapy, yoga, cognitive behavioral therapy, because it is triggered in your brain. There are going to be some things that just trigger the fibromyalgia, and anything you can do to avoid those triggers, and then when they happen, to be able to kind of tamper them down and get back to a good stopping place, that is what you need. So, yeah, basically, here we are. This is a great picture that is kind of confusing because what are these? Hey guys, we forgot to label them. But yeah, more common in fatigue, brain fog, are going to both happen in multiple sclerosis and fibromyalgia, okay? Fatigue and brain fog are for both of those, okay? But the reasons why they happen are different, right? You're going to be tired in multiple sclerosis because you don't have the energy. You've got this brain fog because you don't have the energy. It takes so much energy for you to move every day because you don't have enough acetylcholine that you just get tired. Whereas in fibromyalgia, there's fatigue and brain fog. This is a central nervous system issue. You are feeling pain all the time. You're stressed. It's like all those signals have been amplified. And so you're going to have that brain fog and that fatigue because you essentially just are so in pain. Not great. They have here multiple sclerosis. You're more likely to be dizzy and weak. Vision problems more likely in multiple sclerosis. Depression more likely in fibromyalgia. Because remember, fibromyalgia, it sounds crazy to say, but it is all in your head. And you can't really, truthfully, it is a problem. And I'm not saying that to downplay it at all. It's a huge issue. It is an actual disease because your brain has a problem with the pathway of pain where it's just like we have that one negative stimulus, send it down the pain pathway. Not great, right? So if you're feeling that all the time, yeah, I'd be freaking depressed. Whereas in multiple sclerosis, you've got an issue with acetylcholine. You're going to have weakness, dizziness, vision problems. Those are all issues that are due to that specific neurotransmitter and not a pathway where you're just going to be in pain. Those don't really have much. It could happen, but less likely. Irritable bowel syndrome, fibromyalgia. IBS is kind of, it's where you're pooping a whole lot. It's irritable. You may have periods of constipation and then diarrhea. Whereas in multiple sclerosis, you're more likely, if anything, to have constipation. Bowel or bladder problems. Oliguria, constipation, because it takes a lot of energy for your gut to move, right? Numbness and tingling is more likely in multiple sclerosis. Why is that? Because it is a neurotransmitter problem. You're going to see sensory issues with that neurotransmitter problem. Fibromyalgia, yeah, it's sensory, but it's pain. It's literally the sense involved is pain. That's not really a sense. It's not one of our 5 senses. Pain is like an extra one that hurts and is not fun. Nobody wants that. And persistent widespread pain, fibromyalgia, of course, right? Because multiple sclerosis is you're more tired. Yeah, it might hurt because it aches, but it's tired more than anything else. And then muscle spasms. Muscle spasms in multiple sclerosis because of acetylcholine issues. Yeah, anyway, what's similar, what's different? Nursing actions, as well as your nursing indications, know medications, and then knowing what's common between them and what's different between them. And that's why I wanted to go through it, even though it's not perfect, hence these ones that haven't been addressed at all. It's still important to think about because it forces you to connect symptoms to pathophysiology, which is sometimes annoying and really not that useful in practice. Kind of, sort of, unless we're talking medication education. But at the end of the day, it's really important that you know what's going on with these disorders so you can do well on the test. Let's all be real. And look at that, we got to the end. So we'll call this another successful lecture moment.